trickle in. We're very fortunate to have Dr. Grubb, who will be presenting in a moment, and ask Dr. Lavi to present him. Just a few quick announcements. Next week, unfortunately, our visiting professor had a death in the family, and we've had to cancel next week. So we'll follow up with information about subsequent weeks for grand rounds this summer. Hope everyone's enjoying the warm weather and the sun. And we're very excited today to have a guest speaker that'll teach us all about dysautonomia. And I'm going to have Dr. Lavi introduce him briefly before we get started.
Thank you. Good evening, everyone. It gives me great pleasure and honor to welcome Professor Grubb to our cardiology grand rounds today. Professor Grubb joins us today from University of Toledo, Ohio. He's a distinguished professor of medicine and pediatrics and practicing electrophysiologist as well. Over the years, he served on numerous editorial boards and committees and authored hundreds of articles and book chapters. He was also the recipient countless of teaching awards and research awards, including year-over-year recipient of the President Awards for Excellence in Creative Scholarly Activity from the University of Toledo, which he had received this year as well. Please join me in congratulating him on this achievement as well. Professor Grubb is a board member of the National Dysautonomia Research Foundation and world expert in dysautonomia. He is the founder and the current director of the Syncope and Clinical Autonomic Disorder Center in the University of Toledo. Dr. Grubb was among the first researchers in the United States to employ head upright tilt table testing for the diagnosis of vasovagal syncope. The center is the world-renowned for its treatment of patients experiencing syncope and patients with disorders of the autonomic nervous system, such as POTS, and in recent years, also long COVID. He is a brilliant clinician, and his research and innovations in patients' care had contributed immensely to our understanding and treating patients with autonomic disorders. Few of you asked me how I came across to meet Professor Grubb. We had a very complex case of a patient post-COVID, and we were puzzled and struggling with a diagnosis and treatment. And I reached out to him over an email to see if he can assist us. He immediately responded, and we set up a telephone conversation. I believe it was also in the weekend that we talked. He spent more than a couple of hours on the phone to go over the case in great details. And after that, over the following month, we discussed the case numerous times, countless of hours. He has an inspiring dedication and enthusiasm for patient care and a great role model. Thank you. Without further ado, please join me in welcoming Dr. Grubb, who will be discussing with us autonomic disorders, a guide for the perplexed. We have a lot to learn. Thank you.
It is a true honor and pleasure to be here and be able to share this information with you. I wrote the accept section of the board review thing on these kind of disorders, so I want to try to cover the things I know they're going to ask on the boards. And I know they're going to ask them because I wrote the questions. I started out not doing autonomic things, but by looking at syncope. And just so we have the same definition, syncope is a transient loss of consciousness and postural tone with spontaneous recovery. If you get 20 minutes of CPR, that is not syncope, that is sudden death. And I get these consults to the ICU to see someone for syncope, and it's, they've had like an aborted sudden death episode. It's derived from the word there, syncopa, which is Greek for cutting short. The CDC keeps track of the frequency of various things in the United States. So when people want to know how many MIs there were, how many broken hips there were, it's a CDC database. One of the odd things about it is they look only at primary diagnoses, and the way they do it is they look at a certain representative number of hospitals and then measure, look at the codes for admission, and then make a projection on the rest of the country. So they don't actually measure things. But each year, about 3.5% of all ER visits are due to syncope. About 35% year to year get admitted to the hospital. One of the odd things is between 1% and 6% of patients are admitted to the hospital. Why the variance from year to year? I think it's just because of the way they do their counting. If you have a syncopal event, fall, break your hip, broken hip is the primary diagnosis. If you translate that to numbers, it's 300,000 ER visits a year and 75 to 100,000 hospital admissions every year. And if you throw in outpatient visits, there's about 1 million new patients per year. Now, there are 1 million different things that cause syncope. Many people here can tell you about the different heart rhythm disturbances that can do it, such as hypertrophic cardiomyopathy, long QT syndrome, et cetera. What I'm going to focus on is what most people are unaware of is the autonomic causes of it. So the autonomic nervous system, which I didn't know much about before I started this, or the human nervous system in general, can be broke down in several ways. You can break it down central and peripheral, and you can break it down further into somatic and autonomic. The somatic system is the part that you have control over. It's a part that you use when you use your muscles. It's involved in pain control, and it's fairly simple. It's a linear system. Each cell in the brain has one nerve that goes to one place. 1 + 1 = 2. And so a neurologist can examine somebody and tell you exactly where the stroke occurred in their brain by doing that. Now, the problem is the autonomic system has 100-fold more to do at any moment. If you're laying motionless in bed and not moving, you still have to breathe. Heart still has to beat. You have to maintain your blood pressure. You have to control bowel motility. There's not enough room in you for a linear system to do that. It'd be like having every outlet and light bulb in your house have a different wire coming off the electric pole. So what we have is systems that we've learned to duplicate in our machines in our homes, which is to have junction boxes. Each autonomic cell in the brain goes outside the brain and spinal column to a junction box called a ganglia. And from that point can come 20, 30, 40, or 50 nerves that go to 20, 30, 40, or 50 places. So 1 + 1 = 50. It's a greater than logarithmic expansion. That makes it so small amounts of neural tissue in the brain can control large numbers of functions simultaneously. But it also means if something goes wrong, a lot will go wrong simultaneously. I've colored the areas that are involved in the somatic system in blue here. That's the majority of the brain. The other colored areas show areas that we know participate in autonomic regulation. Incoming information from the body about what your blood pressure is, et cetera, go into a place called the nucleus tractus solidaris, which is in the brainstem area. It's relayed to an area in the pons called the ventrolateral nucleus, and then ultimately to the hypothalamus. Within the hypothalamus, there are little subgroups called nuclei, and the medial perioptic nucleus is the one involved in heart rate and blood pressure control. So the one that usually involves us cardiology types. But there are a whole bunch of other areas that are involved in this. When I give this talk to neurology, I focus more on these, and I didn't put it in this talk. But these are other areas that have been identified. So it's an integrated circuit within the brain with multiple areas participating. What does it do? It keeps you alive. It controls heart rate, blood pressure, body temperature, bowel motility, skin turgor, sweating, all the things that you do not have normal control over. We normally divide it into two components, sympathetic and parasympathetic. The term sympathetic was used by Cannon, who was at Cambridge, who was researching the autonomic nervous system, and he coined the term autonomic nervous system. It was once called the vegetative nervous system. And he was doing dissections and doing this stuff. And he went to lunch, and he had a buddy who was a classic scholar. And he was telling him, I just dissected out these nerves on either side of the spinal column, and I think these things are important. He goes, well, that's really funny because the Roman physician Galen described the exact same thing in the year 200. And he thought that those nerves on either side of the spinal column made the organs of the body work in sympathy. And Cannon was like, what? Huh? And he looked it up, and it was like, yup, he's right. And so he named it sympathetic nervous system to honor Galen. So the sympathetic nervous system is the fight or flight part. The parasympathetic is the rest and digest part. The end terminals of the sympathetic system use norepinephrine to work. The end terminals of the parasympathetic system use acetylcholine to work. But the ganglia of both use acetylcholine. Okay, it's used in both sets of ganglia. Now, this was all well and good until the late 1980s when Dr. Jeffrey Bernstock at the University of London began looking at the autonomic innervation of the gut. And to his surprise, the same nerves contained acetylcholine and norepinephrine and nitric oxide. What's that do to this system? Kind of trashes it, doesn't it? We don't have a replacement. We know it's not right. We know this is not inclusive enough. And we've also found a whole bunch of other neurotransmitters that are critically important in autonomic regulation, most of which just have numbers and letters that don't fit anywhere in there. So we're kind of like where quantum mechanics was for a point. You know, we know the system that we've developed is inadequate. The model that we made is inadequate to explain the findings we have. We just don't have a replacement yet. So we continue to use the old model, even though we know it's not fully adequate. How does the brain know what your blood pressure is? You have unmyelinated C fibers that are called mechanoreceptors that line all the vascular systems. Most of them are in the heart. The heart is the major blood pressure sensor. 2/3 of all mechanoreceptors in the body are in the posterior aspects of the right and left ventricle. The second most common place is the aortic arch, and third is the carotid body bifurcation, but they're in everywhere. And when they're stretched, they give off more electrical activity. So what your brain is measuring is electrical output from these cells to tell what your pressure is and to tell where it is. So if there's more blood in the lower half of you, it can tell it by monitoring electrical output from these. So there's electrical output that goes in, there's input, processing, output, feedback. The system can break at any point along there. It's all interwired together, okay? Now my ex-son-in-law was an AI expert for Cisco. And when I showed him this, he was astonished. He said, this is how we're wiring neural networks and computers for artificial intelligence. We're using this exact plan. So we're duplicating what nature already figured out how to do. When you stand, gravity will attempt to displace downward 1/3 of your blood. The displacement is immediate. You must respond to it immediately or we all pass out. So how does your brain know that something's happened? Well, when you stand and gravity pulls blood downward, the mechanoreceptors in the lower half of the body start firing like crazy, and the mechanoreceptors in the upper half of the body stop firing. So it sees this dissymmetry and then increases sympathetic output, resulting in an increase in heart rate, an increase in myocardial contractility, and a tripling of peripheral vascular resistance. The vessels just go, and then that pushes blood up to your head. It does it like that. So you can jump out of bed, jump out of a chair, do double backflips, your pressure will stay the same. Once you're upright, you got to maintain it. Gravity keeps pulling on you. If you can't continue to maintain those corrections, gravity will win, you will lose, and blood will be pulled downward. How you feel depends on the displacement of blood. If it's a small amount, you'll feel tired. If it's more, you'll feel like you can't think, can't focus, can't concentrate. More still, you'll get lightheaded, dizzy. More still, you'll see black spots, get tunnel vision. More still, you'll pass out. Now, when that starts to happen, your brain looks and says, oh, what's going on? I can't get enough oxygen. So it tries to rev everything up. The trouble is the vasculature, and I'll go over why, isn't listening. And so in a normal person, increasing heart rate, if you had normal volume and normal vascular tone, would increase your output and make you feel better. But in many of these patients, the blood is being pulled in the lower half of the body in the mesenteric vasculature. The heart can only pump the blood it receives. So if you're pulling a whole bunch of blood there, and it's a tremendous amount, then going faster is actually pathologic. We have a backup system that's uniquely human. We're the only truly two-legged critters on the planet. And so we have a thing called the skeletal muscle pump. What it refers to is contraction of the leg muscles, and to a lesser extent, the abdominal and arm muscles, compresses the venous system and propels blood back to the heart. A healthy set of legs can raise your pressure 10 points. It's usually there for backup purposes in most people, if you're standing a long time, if it's super hot out, if you're dehydrated. But people with autonomic disorders unconsciously learn to use it all the time. It is a 24/7 compensatory mechanism. So Dr. Richard Sutton and Dr. Rose Kenny at the Westminster Hospital in London in the mid-1980s figured they could uncover someone's predisposition to syncope or autonomic disorders by inhibiting the skeletal muscle pump. That's all it is. So they put people on a table meant for weight bearing and then tilted them upright to 60 degrees, and that's it. They just left them there at 60 degrees. Well, big deal, right? How long do you stand on your feet when you do a AFib ablation or a BIV? You know, it's like you spend hours standing there with a lead apron. It's fine. You get to do it. However, if you have very poor autonomic tone and you turn off their compensatory mechanism, they will crash, and they will crash quickly. Now, not only did this give us a diagnostic modality, but for the first time, we could measure what was happening as it was happening. We could provoke these to occur, and we could measure echocardiograms and thoracic impedance and abdominal impedance and serum catecholamine levels and electroencephalograms and sympathetic nerve traffic all at the same time. We could see what was happening as it was happening. And we learned that most of what we thought we knew about these disorders was wrong. You can say anything you want as long as nobody ever looks. This is the second patient we ever did. This was in 1988. It was still a research test. And this was a nurse that was recurrently passing out. And she was fired from her job at a local hospital because she kept passing out. She got the $1 million or $1 billion workup circa 1988 and was told what we tell everybody when we don't know what's wrong. You must be crazy. So we tilted her. She was like saying, I think I'm going to, and then she didn't finish that sentence, and her blood pressure and heart rate went to 0. She began to convulse. She was incontinent. And my nurse and I were standing there going, wow, that's pretty cool. And we put her down, and you notice she has a rebound hypertension. She overshoots. It's like a Simoji effect because she's flooding her system with catecholamines. And when you take away the gravitational stress, then she's hypertensive. So if you found her on the ground and took her blood pressure, it'd be high. And this is what her heart rate did. Now, I didn't know what I was doing in those days, not that I really do now. And I put her in the hospital and put a halter on her. And she was nice enough to pass out on the 3rd floor cardiology floor while wearing the halter. And this is what it looked like. So we realized we were duplicating these spontaneous events. By the way, that a thing over there is not a heartbeat. That's the artifact from her hitting the floor. So we realized we had a way to duplicate what was probably going on in nature. Now you might say to yourself, well, so why care? Who cares? I mean, they pass out, so what? I don't know if you know who Will Rogers is. He was a radio commentator. Jon Stewart copied his program from the program that Will Rogers had on the radio. The same kind of political commentary and things like that. And this is one of his sayings that I thought was kind of cool. So this is the wife of a CT surgeon who passed out and doing dishes, broke her jaw and broke her zygomatic arch. It's called a blowout fracture. And then ENT and ophthalmology spent the next 3 hours putting her head back together. This is a kid from California who kept passing out, who rolled down several sets of concrete stairs, broke both arms or her face. So it's not a problem unless that's your kid. Then it's a problem. This is a kid that was a student who passed out, hit a desk, and broke her teeth. So as a separate thing I can talk about on some other occasion, in order to improve my surgical skills, I actually did a mini fellowship in plastic surgery. So one day a week, I was a plastic surgeon and scrubbing with them and trying to learn their techniques. And the one day I was there, we were called to the ER, and this lady had passed out at her home, but she had this glass coffee table with really sharp edges on it. And she hit just the right way to do this. So I got to help put her head back together with the plastics people and then see her in clinic, and later she ended up with a pacer. But it's not a problem, right? I mean, unless that's your wife or a friend or. So we learned that not everybody crashed and had syncope per se. Many people just got lightheadedness, dizziness, vertigo, but some people also looked like they were seizing. The first patient we did that I showed you her tracing looked like she was seizing. So we began to wonder if people were having episodes of what we call convulsive syncope rather than epilepsy. Because there's a series of things you feel as the blood pressure goes down. We did lower body negative pressure things. So you get in this thing that looks like an empty whiskey barrel. And then you have this thing that looks like a shop vac, and it pulls blood downward, and you're laying down during it. We did this way so we could lower pressure 1 millimeter at a time, and then measure transcranial blood flow and electroencephalograms and other things. I had it done to me. I was oftentimes one of my own research subjects. It is a most unpleasant experience, I can tell you. So next I'll show you. So the other thing I had to do this research, I had to start to learn to read how electroencephalograms. If you're an electrophysiologist, it is not that hard. I mean, you're used to looking at patterns, and so you just are learning a different set of patterns. So this is a true epileptic event. This was a person who was having temporal lobe epilepsy, and I just underlined the part that the neurologist who was teaching me was pointing out. This is hypertonic spike and wave activity. It's in the mid-temporal region. There are 24 leads that are measured. Next, I'll show you a 17-year-old who was having recurrent seizures, failed every seizure medicine, and was about to be referred out of town for a procedure called a corpus colectomy. Do you know what that is? They cut the middle of your brain out, corpus colectomy. Your seizures will stop along with a few other things. And the pediatric neurologist, I was giving a lecture to neurology and peds neurology because I have a joint appointment in peds. And he came up to me and said, I have a bad feeling about this whole thing. I really don't feel good about this whole thing. You know, he only has episodes when he's upright. His EEGs are always normal. But remember, an EEG misses 1/3 of the brain. You can only see 2/3 of the brain with an EEG. If it's deeper than that, you can't see it. So I said, why don't you guys look at him? So we were doing a study at the time, and we would do, this is pre-portable digital EEGs. So we took the tilt table test we had a long-term epilepsy monitoring unit, and they had a camera so we could have a split screen recording of the patient on one side and their EEG on the other. So we could then play it back and say to the parents or the spouse, is this what they look like when they're seizing? And we could blind it and play it to an epileptologist and say, do you believe this person is seizing? So at 17 minutes into the study, and I remember because it was the same as his age, his blood pressure went to 0. And he began to have what looked to me like a grand mal seizure. And this was his electroencephalogram. Now, you don't have to be an electrophysiologist, or a neurologist to tell that looks different. That is diffuse slow wave activity. That is cerebral hypoxia. So when we played this back to the epileptologist, not just the regular neurologist, he said, that person is having a seizure. So these could mimic seizure activity. There was a study published by Adam Fitzpatrick at the Manchester Hospital in England, where using a variety of technologies such as implantable loop recorders, et cetera, they did a study looking at patients diagnosed with epilepsy and found that 40% did not have epilepsy, had a cardiovascular cause, often these things. 40%. It was published in JACC. So we began to see patterns emerge in the people. So we kept getting referred all kind of people. And at first they had neurocardiogenic or vasovagal syncope. But then we started to get other people who had very different patterns. And we noted that the patterns seemed to correspond with the symptoms they were telling us. And we realized we were probably seeing different disorders. So we began to try to organize it. Now, we have to realize, that any attempt at organization or classification is arbitrary. And this is a quote from Heisenberg, since the measuring device has been constructed by the observer, we have to remember that what we observe is not nature itself, but nature exposed to our method of questioning. Anytime you do this, there's a prejudice in that you're bringing to it. So we broke them down into 5 major groups. I won't talk about all of them. This is a classic neurocardiogenic or vasovagal response. These people are just fine in between their episodes, and then suddenly their blood pressure will go to 0. And in about 1/3 of them, the heart rate will also go to 0. They'll hit the floor, and if they don't kill themselves when they get up, they'll be just fine until their next one. So in between, they're fine. It's almost like having epilepsy. We then began to notice a lot of patients were referred who were older, who had Parkinson's or other neurologic disorders. And when we stood them up, all the blood in their body just drained downward, and their heart made no compensation for it. They were just flat. These people were completely deinnervated. This is the first recording of a person that we saw that we later felt had POTS. This is from 1991 or so. And this is a woman who was a ward clerk, who was a triathlete, who actually ran in the Ironman triathlon in Hawaii, got a really bad viral infection, and then said, I can't get out of bed. I get out and I feel like my heart's beating out of my chest. I feel like I'm going to pass out every time I get up. I can't function. I can't think. And when we tilted her, her heart rate went from 70 to 160 and her blood pressure dropped a tad, not a whole lot. And as we watched her, we looked and saw that her feet were turned red, then blue, then like purple. And we said, wow, that's pretty cool. So I brought her back and we did a blood pooling analysis where you give technetium, you label red cells, you stand them up, and then you take a gamma camera so you can measure where the blood is. Normally 15% of your blood is in your legs. In her, it was 30%. So what you were seeing is an inability of the peripheral vasculature to constrict with a compensatory increase in heart rate. But think about heart failure for a second, right? What keeps you upright? Heart rate, contractility, vascular resistance. What do you lose in heart failure? You lose contractility. So what do you increase? You increase heart rate and vascular resistance. They become pathologic, right? And we try to inhibit them. In POTS, you lose vascular resistance, so you increase heart rate and contractility. Same thing, just different parts of the triad. So we began to organize it. This is a system that was adopted internationally. We break these down into reflex syncopes, POTS, and then autonomic failure. Again, I just showed you that. And again, what's happening is blood is pooling in the lower half of the body. These people are de-innervated in the lower half of their body. Oftentimes they don't sweat. They have a small fiber neuropathy. They have a number of things that indicate some kind of de-innervation. When you stand them up, you can see it. This is supine and this is upright. That's a string plethysmogram, and it measures changes in diameter, and their legs also swell. This is called acrocyanosis when it's there. We define these as POTS as a increase in heart rate on standing of greater than 30 beats per minute, or that exceeds 120 beats a minute in an adult. It's 40 beats a minute in a child and 140 in a child. And the first 10 minutes of upright posture. You'll hear this term used when people don't quite meet those criteria. It actually describes more symptoms. The trouble is there's a day-to-day variance in how much your rates will change. I mean, because you're more hydrated or less hydrated, or the temperature is different. This is not new, by the way. And the idea that it occurs after some viral infection is not new. Many of these patients, 70%, will report an antecedent febrile illness that we have presumed to be viral.
Just press it a little more. Do you know how to do it again? It's on there, but maybe it's not. Sharing content. Do you know how to do it or no?
Just try to reconnect. That way it works. Maybe stop and then try to restart.
Desktop. We don't want to do that.
Stop this. Start it again.
Step page, GIP, IT guy.
I know. Photo is not receiving video from encode. This never happened here before, so I. Use the provider.
Just probably need to reboot the whole thing. Yeah, we're gonna try it. Probably just need to reboot the whole thing.
So I wouldn't know how to restart it, so. Stop it.
Page, the IT guy.
Yeah.
Yeah, I don't know what happened.
You didn't do anything. Currently sharing.
Let's
Oh,
stop
stop
and then
sharing.
go restart again.
Okay,
Yes,
share
and
content. Shared meeting.
It doesn't direct anything at all.
Doesn't recognize anything. Sorry about that.
Anyway, so we don't lose too much.
Yeah.
time.
Go ahead.
These are not new, okay? In 1919, Guy
can call.
I don't know.
Like,
published a paper where he looked at these very same patients.
should be,
He looked at all
maybe it's the
veterans
computer.
of the First World War. The
Do
Spanish
end show
flu
maybe?
decimated both sides, and actually the reason the
Start
First
it
World
again.
War ended so abruptly was because 90% of the troops couldn't function because of the Spanish flu, which was more lethal than COVID. And in 1919, he also, in 1914, they invented a blood pressure cuff. They didn't have one before that, so you could measure blood pressure. But in his study that he published, he looked at people that had suffered from the flu.
People IT.
And what he found, he
HDMI.
described his patient as perfect. He described the active cyanosis, he described the 30 beats per minute increase in heart rate, and he postulated that somehow the infection had done something to them, so their venous system couldn't constrict and they were pulling blood. Okay, you read
Maybe
this.
connected again.
Like, this guy figured it all out. He was just a careful observer. If you look back.
They even come back in again.
We think describes
They even come back in again.
was in from